Well, we've covered a lot as far as management goes, so let's talk about precision medicine and targets and hope for the future. I'll turn to you, Brad. Brad, you'd mentioned what Alzheimer's disease is caused by, defined by. So what are the conceptual approaches in experimental therapeutics that are targeting amyloid right now?
Sure. So I talked a little bit about the process of the pathologic form of Alzheimer, of amyloid that is generated. And there are these soluble stages, and there are monomers, oligomers, and then protofibrils. And something about that process interferes with synaptic function. And then as the amyloid becomes insoluble and deposited as fibrillar plaques that have a neuritic component that includes tau, hyperphosphorylated tau, they interfere with the structure of the brain, including the axons and dendritic structure between neurons, and are thought possibly to have a variety of toxicities at the synaptic level and at the cellular level. And so from the perspective of the amyloid cascade hypothesis, there are various points of intervention, some of which have been tried pretty vigorously and have not worked very well, and some of which have not really been tried. And I think we're refining our thinking about what the different mechanisms of action are. And there have been a couple of recent trials that I think are worth talking about, in terms of where the field is going, despite the failures that we've had. So I just want to mention BAN2401, which is a monoclonal antibody that is really targeting the soluble protofibrils of A-beta. And the, I think, excitement at the AAIC meeting a couple of years ago, the International Alzheimer's Conference, was the reporting on the multi-dose 18-month study of about 800-ish patients with MCI or dementia due to Alzheimer's disease, with the highest dose group that got 10 mg per kg twice monthly, showing reduced brain amyloid on PET and some evidence of clinical efficacy on a couple of outcome measures representing cognition. That wasn't seen in the group that got the less frequent dosing once a month. So I think we're all watching the phase 3 trial of this compound that is maybe a slightly different mechanism of action than some of the other approaches that haven't done so well in the recent past.
So this is a trial that's ongoing now, and it's focusing mostly on protofibrils. What are some other amyloid monoclonal antibodies that are also currently being tested and have kind of withstood the earlier phase testing?
Right, so the gantenerumab is one, and it's really targeting the fibrillar stage of amyloid plaques with the idea that we should be trying also to remove the plaques from the brain. And so the early studies of gantenerumab did not meet primary clinical outcomes, but like all trials, we try to learn from those. And one way we learn is with open label continued follow-up of patients to see if maybe there might be longer term clinical efficacy, even if the primary a priori specified outcomes were not met. The other thing is that in the higher dose arm of one of the early trials of gantenerumab, there was evidence of reduced amyloid in the brain, even though the clinical outcomes weren't met. So I think that's always exciting. And there always are these exploratory analyses of clinical subgroups that can teach us better ways to hopefully target treatments in the future. And so one of the things that was done with that data set was looking at faster progressors. I think one of the challenges that we have in all Alzheimer-related drug trials is that some people naturally just don't progress very fast. And if you happen to have a group like that in your treated arm, you're potentially going to be fooled into thinking that the drug is doing something. If you happen to have those people in your control arm, you're going to be potentially fooled into thinking the drug is doing something. So that's why it's always important to examine whether the different groups in the trials are representative of what we think the placebo arm should be, for example. So in that study, the sub-analysis that was purely exploratory after the fact of the faster explorers suggested that not only did they have the reduced brain amyloid, but maybe they also would have met some beneficial clinical outcomes if that had been the group that was the sole group in the study. So I think these all lead us to feel that there might still be some signal, both in terms of the target engagement, which is reducing the amyloid plaque, and in terms of possible clinical efficacy, which is why these cohorts are being followed in open label trials, and why there are new studies of this compound both in the dominantly inherited Alzheimer network of people with autosomal dominant AD and also in sporadic AD with ongoing clinical trials that are recruiting new patients with prodromal and dementia stage AD.
Right, so that's actually an important point. One of the exciting things is, like, as you mentioned, for BAN2401, the earlier phase data had suggested that you can actually remove amyloid from the brain. And some of the studies in the past that were on the later stages, either the patients didn't have amyloid in the brain, so they were included years ago before we had PET scans and CSF, or there were more severe stages. So what are plans for things like BAN2401 to go even earlier in the disease process for people without symptoms? Are there, I think you alluded to that.
Right, so in the Diane study, and there are other studies ongoing of so-called preclinical Alzheimer's, which we haven't talked about today, but I think is a very hot area in the field that's not yet ready for clinical practice. We don't want to talk about it as if people should be looking for their primary care doctor to perform molecular biomarker studies on them, but they're normal. I don't think we're there yet. I hope we will get there, because if we get there, that's going to mean we're able to do something about it. So I think that the field is saying we know that amyloid gets deposited in the brain maybe as long as 20 years prior to when people develop substantial symptoms. And there's the tau pathology that also precedes the symptomatic stage of the illness. And there is dysfunction of brain networks and even atrophy, if you measure it carefully in the brain with MRI, that can be detected prior to symptoms. So there's this fairly long preclinical stage that is now the subject of a number of ongoing studies, both in genetic forms of AD and in sporadic forms of AD, where primarily the amyloid-based strategies, including the use of gantenerumab, is being evaluated with regard to whether it can delay the onset of symptoms, whether it can reduce brain amyloid, and hopefully do both of those things together, and hopefully have a meaningful impact on when people develop symptoms, even if they have the beginnings of the Alzheimer pathologic process happening in their brain.
Right, so kind of goes back in one way to what you were saying, Mary, about the value of timely diagnosis and allowing people to be at the highest point to make their decisions, including whether they want to become involved in research. And we're also hearing that there are studies that are either launched or being launched that can look at people who may have amyloid in their brain but don't have symptoms. So one of the ones that recently has been brought up is again BAN2401 being put in early in the sort of A45, A3 studies. So again, this is a hope for the future that people can participate.